Hello, this is a detailed guide for radiologists and radiology residents on how to do tomosynthesis-guided breast biopsies. In this movie, we will be using the Hologic Affirm upright tomosynthesis unit and the ATEC Aviva needle, but the same principles apply to any equipment that you're using. So when would we do a tomosynthesis-guided breast biopsy? Well, you can do pretty much any lesion which is visible by mammography, but when would we use this unit as opposed to a regular prone stereotactic unit? Well, lesions that are only visible tomographically obviously need a tomographic means of biopsy. Patients who can't lie down on their stomachs for a prone stereo. And we've also found it's very good for very posterior lesions in the breast. And it is a much faster means of biopsy if this becomes an issue. What's it not so good for? Very faint calcifications can be sometimes difficult to see on the tomo biopsy unit. It's become less of a problem as we've had more experience, however. Very long procedures, such as double biopsies, the patients are a little bit more prone to fainting if you have them in the upright position. If you do not have a decubitus table, if you must use an inferior approach and you do not have a decubitus table, then you will need to use the prone table for biopsying those lesions. And finally, because patients are often biopsied in the upright position, if they are prone to vasovagal episodes, then you're going to want to have them preferably in the prone position for that. We're going to go into some detail about the tomo biopsies here, but we've assumed that you've already watched the regular stereo biopsy movie and you're aware of the concepts around vacuum needle biopsies, the concepts about stroke margins for stereotactic biopsies and the indications for stereo biopsies, as we will not be going into those here. Before you start the biopsy, you have to identify to the technologist what approach you're going to use. Generally speaking, you want this to be the approach that's closest to the skin surface, or sometimes you're going to want to be using the approach that would allow you to distinguish the calcifications best. Let's illustrate this on this patient. So we have our CC view and our true lateral view, and this patient has 3 groups of calcifications. Number 1, number 2, and number 3. And the same here, number 1. Now, calcification groups 2 and 3 are directly overlying each other on the lateral view. Now, to get at group 1, we can either come from a lateral approach, or we could come from a CC, and it doesn't really matter a whole lot with group 1, it's pretty much equal distances. With group 2, however, although it's slightly closer to the lateral side of the breast than it is on a cranial caudal biopsy, it is overlying calcification group 3 when we look from the true lateral view, and it'd be very difficult to be sure that we're actually getting group 2. So I would want to come from a CC approach so I can isolate group 2. Let's look at group 3. Well, group 3 is pretty deep in the breast. It's pretty much straight retroareolar. It's equal distance between the medial and the lateral aspects of the breast, and is closer to the superior or the cranial aspect of the breast, same as group 2 is here. And again, I would use a cranial caudal approach to biopsy group 3. Here is a radiograph of the phantom that we're going to be using to demonstrate tomographic biopsies. This is a ham with eggshells injected in the center, which you can see very nicely here. Just to talk very briefly about positioning the patient. Of note, in this video, we are only going to show you positioning of the patient in the upright position and not in the decubitus position. The breast is put in a moderate amount of compression after placing it on the image receptor plate, really just enough to keep it immobilized during the procedure. This is a patient who has been positioned for a cranial caudal approach for a tomo-guided biopsy. You can see our compression plate here with the hole in it. Note that you always want to put some good padding behind them to make sure that the patient doesn't move, make sure they're comfortable before you start. And here is a patient who has been positioned for a lateral approach. The same applies. We will often put sterile tegaderm between the paddle and the patient here. This helps the breast compress some, and it also stops the patient's breast from moving within the device during the biopsy. So now your patient is already positioned correctly. Let's move on to imaging the lesion and targeting. This is the hologic tomobiopsy unit screen, and we're pretty much always going to start by doing some form of a scout, depending on the projection, to just make sure that our lesion was in the field of view. So here's our scout image. You just want to check the borders of the paddle opening to make sure that your lesion, seen very clearly here, is well within those borders. And then you go on and do the first tomo image for targeting. Here's a scroll through of the initial set of targeting images from the scout tomo, just showing how that cluster of calcifications comes in and out of the focal plane. On the hologic affirm unit, you use this scroll bar here to go through the tomographic images to select the slice which shows the target best, and then left click to select the target once you have the cursor over the lesion. So you scroll through your tomographic images to find the best target. Once you've found it, left click the mouse in the center of the target. You then want to select that check mark on the left, which will send it to the device. If it's not the needle you want, select the correct needle. In this case, we're using the 12 millimeter Aviva Petite needle. And then finally, once you've confirmed your targets, touch that little mail sign, the envelope sign, and it will send it to the gantry. So we've selected our device here, and it's the petite needle in this case. We've sent it using this little envelope sign here, which shows now our target coordinates, and it's at that point it's going to come up with this screen below. Let's zoom in and take a closer look at this. So what we want to see on this screen is we want to see all three of these figures here being shown in purple. This first figure at the top is going to make sure that we have sufficient depth between our biopsy window and the skin surface. The bottom figure down here is our stroke margin between the tip of our needle and the back of the breast and the receptor plate. And this one in the middle should be 0 to show that this is when we're at target. Now, if any of these show yellow, that means warning, but it doesn't mean you can't proceed, but it has a close margin either to the skin surface or the rear of the breast. If they show red, however, you should not proceed with the biopsy in this case. You should either change your targeting, or you might need to change from a different approach to give you a better stroke margin or skin depth. There are some tricks to deal with skin depth that we're not going to go into in this movie. Before you move the device to the correct target, read the target out loud to the technologist who can confirm it on the display by the unit here. The target is moved by squeezing the front and back buttons on either side of the display face. At that point, the device holder will move into the correct position for initial targeting. And you can see by both X and Y being yellow here. Now you'll notice that although the coordinates were sent to target, and you can see here that these are the target coordinates that you can confirm off the console, there is a difference between the position that the needle is now and the required target coordinates. It's just a tiny bit in the X direction, it's more in the Y, and it's significantly more in the Z. The reason that there is such a difference in the Y is because of the angle of the biopsy device as it comes down to the skin surface, as we'll see in a minute. The Z is because the needle has not yet been advanced to the target position prior to needle deployment, but you do want to see both the X and the Y being yellow, and the Z can remain white before you advance the needle. This is just to show you a view from the side to show you how the device holder comes at the breast at an angle on the coordinates used by Hologic. This is X, this here is Y, and then the Z is going to be the depth of the needle. So as you can see, as the needle comes down, that Y distance is going to be reduced eventually to 0. Here is what we have on our prep tray. We have chlorhexidine for cleaning. We have 2 syringes of local anesthetic, a 10 cc without epi and a 20 cc of 1% lidocaine with epi. Our scalpel, mosquito forceps, a 20 gauge spinal needle that we use for deep anesthesia if we need it, our steri-strips and some Q-tips for applying the benzoin solution, gauze swabs, and then we have our clip that we're going to use ready on the tray. After the gantry has been moved to the correct position, you then want to get the technologist to swing the camera arm out of the way for her to be able to get the needle into position. It won't slide on if that camera is directly ahead of it. Once we're at this stage, we're then ready to start with preparing the patient's skin. So clean it thoroughly. We use chlorhexidine solution. And then wind the needle down until it's very close to the patient's skin surface. You can see here, and that will help you identify the exact spot where you need to apply the local anesthesia. We start by giving about 5 cc's of 1% lidocaine without epinephrine. We angle the needle as we find it helps us direct it appropriately along the track we want to use. You want to make sure you get a very nice subdermal bleb of anesthesia and then inject down from there to approximate target depth. Mary Mayhem here doesn't have a dermis, but I think you get the idea. We then change to 1% lidocaine with epinephrine and inject about another 5 cc's, maybe up to 7 cc's, this time deeper to make sure that you go to full needle depth. And as you can see, Jason here is injecting around the needle as we go. The remainder of that syringe of 1% lidocaine with epinephrine gets attached here to the white injection port at the back of the device. The gold port here is used for the irrigation solution. So you want to make a scalpel nick, usually down to the green plastic is about the right size. Vertically down in the patient. Open the incision using some mosquito forceps. And you often need to pull back a little bit with your left hand, holding those forceps open as you wind the needle down. And that helps reduce the skin tethering. You're going to be winding down here to the target distance. Use the knurl knob at the back of the biopsy device. And you want X, Y, and Z all to be green. Close enough. Now you can see that the needle has been wound down to the correct target position prior to deploying the needle, and that both that X, Y, and Z shown here should all be showing green. If they're not showing green, you need to check your position. Always make sure that your needle guard here is advanced close to, but not directly touching the skin surface before you deploy the needle and before you do any biopsies. Before you deploy the needle, warn the patient they're going to hear a pop like a champagne cork. Deploy the needle by pushing the green button. Just to show you it outside of the patient what happens. It's going to go forward 2 centimeters, regular needle, 12 millimeters for the petite needle. We now inject another 5 cc's or so of lidocaine through the back port, turning the device as we do to anesthetize the biopsy area. Press on the foot pedal to start the biopsies. Warn the patient there'll be a whirring noise. It will take 1 biopsy every time it beeps. We'll take a biopsy, then we'll turn the device, and we usually turn by 2 o'clock each time, taking a total of 6 biopsies around the circumference. You can just see here in the window what position you're at. Each time it beeps, turn it, and stop after you've taken the initial 6 biopsies. You can see the biopsies going up the plastic tubing here being flushed by the irrigation fluid. Here are the controls on the vacuum unit attached to the biopsy needle. When you are performing biopsies, this is going to be deployed. You then use the lavage button to be able to flush irrigation solution through the vacuum needle and the biopsies back into the pot. And then you'll need to go back into biopsy mode if you need to do more biopsies. As the lavage mode runs, you will see 1 or 2 more additional specimens running through the tubing down into the specimen pot. This is really important to get those last specimens. Make the specimen pot a little dependent to help the flow, and gradually turn the needle round in the patient to irrigate the cavity. Undo the gold connection, and that will flush the last of the saline into the pot, and you can then remove the basket, replace it with a second clean basket and do it back up, and reattach your saline flush, that's the gold tap there, at the end to keep some irrigation going while you check the specimens. In patients who have non-calcified lesions, we will do a second tomosynthesis image to look at the site of the biopsy cavity, and we're going to be comparing the site of that cavity, in particular the level, with the original images which were taken before the biopsy. Use mosquito forceps to spread your specimens out on the wet filter paper. And then radiograph them using a conventional mammographic unit on magnification setting or in a specimen unit as shown here. We use the Trident specimen unit for our specimen radiographs. It's very nice. You put the specimen in and then you just press this X-ray button until it beeps. Before you start, you always just want to check that the correct patient identification is up on the attached computer screen. When you place the specimens in the unit, if you're on the bottom rung, which is the lower degree of magnification, these rungs here and here, you need to have all of the specimens within the outer set of squares. If, however, you need a higher degree of magnification, for example, with really fine calcifications, you move this perspex tray here up to these higher rungs, and you must then have all your specimens within the inner set of squares, or they will be off the image. Here's the specimen image that comes up. Here's what we see on the Trident after the image has been taken up, and you can see here there's a variety of different options to be able to zoom, magnify, or change the grayscale. You can also do some basic annotations, and then once you're happy with the image, just select Close Patient and the image will print. To remove the Eviva device, you need to press the little plastic lever here and then just pull straight up and out of the patient. There are several different clips you can use for the device. You need to make sure that if you're using a petite needle, you use a clip designed for that needle. There are also several different shapes, and there are different clips if you have a very superficial lesion, and you can just check with the technology manufacturers your particular needle as to what clip you should use in that circumstance. Always be very careful not to touch the sterile end of these clips before you insert in device, and we recommend that you change your gloves after doing the biopsy and immediately before inserting this clip. Clips are deployed just by depressing this plunger until it clips after you've hubbed the device in the sheath. So here we're removing the needle from the sheath. Just take it out carefully and giving it to the technologist. We're then going to place the clip, fully engage the clip until it clicks, deploy the plunger, Turn it through about 180 degrees and then carefully remove it, leaving the sheath in position to take your post-clip tomosynthesis view. And here is that tomosynthesis view. We have the original post-biopsy one at the top, we have our clip at the bottom, and we're just checking to confirm that the clip is at approximately the same level. So here is the specimen radiograph from our patient. As you can see, we got a little over-enthusiastic with inserting our eggshells here, so we have plenty of calcifications, not all of them within specimens, but we usually identify for the technologist the specimens which contain calcifications, and they put those into a separate pot. So the technologist will use the radiographs to be able to separate out the specimens that have calcifications from those specimens which do not, and this aids the pathologist. Once you've confirmed the clip position, you can rotate the sheath out of the patient, take the compression off her breast, and apply some compression to her incision for about 5 minutes. We would obviously at this point normally be removing the patient away from the device. Over the incision we put a little bit of benzoin compound to help the steri-strips adhere. And then we use 2 to 3 steri-strips across the incision, making sure you efface the edges nicely. The technologist will, after she has performed the post-procedural mammogram, which we're not going to show, which you use to confirm clip position, she will put a compression bandage on the patient. Don't forget, if this was a tomo-only visible lesion that you are biopsying, you should do a 3D mammogram after the procedure to check the clip position, not just a 2D. And that's pretty much it.